Welcome to the Monday episode of the Coding and Compliance Roundtable. As always, I am the ringmaster, Sean Weiss, and it is such a pleasure to be here. So, as always, it wouldn't be a show without me saying thank you all so much for tuning in, logging on, and just hanging out with me, my special group of friends today, my very special group of friends. So, we've got a great program lined up for you. We have had a great amount of folks who have signed up for this and who are going to be joining us. So we are excited to have each and every single one of you. As always, I want to go ahead and introduce the team that is on for our roundtable today. Obviously, I do feel like we're playing the Hollywood Squares. We've got Terry Fletcher from California joining us in the top left square.
Hello.
In the top right square, we have Paul Spencer, Senior Compliance Consultant from Doctors Management, works with me on a ton of litigation projects. In the center square, we have Scott Kraft, who is another Senior Compliance Auditor with Doctors Management, and again, somebody who works with me on a lot of litigation projects and some of our large client projects. And then another lady who needs no introduction, the wonderful Miss Christine Hall. Hey, Miss Christine, how are you?
Doing good. Glad to be here.
Glad to have you. I know we only have you for a little while tonight, so I'm not going to waste any time like I normally do, and I'm going to jump straight into this. So, Terry, your job tonight is, as it is on every Tuesday episode, as I get close to the rail, don't let me drive over the cliff.
Okay.
Keep me on track.
Got it.
To each and every single one of y'all out there, we are ready. We'll take on your questions tied to coding, billing, and compliance. We'll do our best to answer those as we move through this thing. But with that said, I think the most logical area to begin this conversation today is with you, Christine. I want to talk about what's going on again. And I know people are probably going to roll their eyes, but y'all need to hang out for just a little bit and listen to what we're talking about here. Incident to billing services. This is a hemorrhoid that no matter how many times you burn it off, no matter how many times you ligate it, no matter how many times you deal with it, it just keeps coming back. So let's talk about the hemorrhoid that is referred to as incident to billing provisions. So Christine, I'm going to kick it over to you first, and then Terry, I want to get your thoughts on that as well.
Thanks. I know kind of dealing with this incident to situation over the past few days here, talking about scope of work. I think that a lot of people they misunderstand the benefit altogether. Let's just be honest. It's not one that anybody really. Nobody ever told me, and I didn't know. And I thought as long as the doctor signed it. And so I wanted to talk about understanding the doesn't change. Like if you're an MA, you're only allowed to do MA stuff. Even come in here and suture this patient up for me, right? You're only allowed to do MA stuff. You also have to watch out with what your state allows. I'm sorry, guys, we're having a really bad, it's South Florida, summers. We just do that. Anyway, but you have. So one of the things in our state of Florida is that medical assistants, they can only be supervised, direct supervision by physicians. So that commissioner or physician assistant who, again, they can provide their own services within their own scope. So that incident too doesn't transfer over to medical assistant supervised by the nurse practitioner physician assistant. So Terry, I can't hear you.
Yeah, just hold on. Yeah, hold it there for just 1 minute, Christine. So
Okay.
you started to talk about something that is really critical, because there is and folks need to be able to understand this. There is a significant difference between qualified healthcare professionals versus your auxiliary or ancillary staff. So, Terry, let me pause. Let me kick it over to you for a minute and let's kind of talk about that. And then we'll go through some of the specific regulations for 60.1 of the Medicare Program Integrity Manual.
Okay. So, and I'm going to kind of go a little bit as far as what Christine was talking about, only because, Christine, you were cutting in and out just a little bit. I think you might have those severe storms like they had in Arizona last night. What is a qualified healthcare professional? Okay, so in 2013, the AMA actually put out a really good definition for QHP because it was all over the place, and the Nurse Practitioners Association, the American PA Association, everybody was saying, you know, all different things of what their label was. And I was like, enough already. We had QHPs, NPPs, APPs. Oh my gosh, the acronyms didn't stop. So in terms of reporting and billing for services, either under incident 2 or reflecting that this is and I'm old school, mid-level provider, the CPT definition says a physician or other qualified healthcare professional is an individual who is qualified by education, training, licensure, regulation when applicable, and facility privileging when applicable. I like that addition. Who performs a professional service within his or her scope of practice and independently reports the professional service. I probably have that and bring that up on my computer. I can't tell you how many times because Sean and I and Christine, and I'm sure that Paul and Scott get this question. Well, my nurse did this. Okay, nurse is generic. Nurse practitioner, nurse, RN, what kind, LVN, LPN. A nurse practitioner is the mid-level that can bill directly. An RN cannot. So if you are not talking about somebody who can bill independently to a payer, then you're not talking about a QHP. So let's just make sure we know that definition. And it also goes on to talk about the distinction from clinical staff. That's a member or is a person who works under the supervision of the physician or other QHP who is also allowed by law, regulation, or facility to perform or assist their specified professional services. But you need to know what those are because they also gave a list of who's included in that. Now, the list of the QHP, anesthesiologist assistant, nurse certified nurse midwife, we talked about PAs, nurse practitioners, but there's also other possible QHPs like physical therapist, occupational therapist, clinical social worker. I know that I've been talking, Sean and I talked earlier about, and you're going to hear it tomorrow on our Terry Tuesday, but we talk about telehealth. And you have to know who's applicable and who are the approved providers. So when we talk about QHP under Incident 2, we are talking about, for the most part, our nurse practitioners and PAs and clinical nurse specialists. Now, obviously, there's a nurse visit, and I'm air quoting, for RNs, medical assistant, et cetera, that could potentially be billed, but there's a medical necessity issue there, and that's not really what we're talking about today.
Yeah. And one of the things I want to make sure we also cover, because a lot of folks in rheumatology, oncology, if you are calling yourself an infusion suite, but you have no physician or no qualified healthcare professional in that suite, and it is not tied into the physical address and the actual location of where the physician or is rendering services, then having it staffed with just RNs and billing it out under the physician number is not appropriate. You can't do it. Yeah, folks, Incident 2, you've got to be 100%, because I will tell you, outside of regular coding, right? Like I'm talking about the use of specific CPT codes for whether it's telehealth, evaluation management services, laboratory testing, whatever it is. This is the number one provisional service that has to be understood 100%, because this is your highest risk audit target outside of specific CPT codes. So one of the things that also I think people, and this one to me, this was absolutely mind-boggling to me, because in the last 2 criminal trials that I was in, the department of Justice, prosecutors from the U.S. Attorney's Office, actually talked about the fact that supervision requires direct supervision. Absolutely. I don't think anybody's going to disagree with me, right? But what they failed to recognize is that even if I am the treating physician of that patient and I am not in the clinic that day, but I have other physicians in the clinic not engaged in administrative services, but they're actually engaged in the clinical care of a patient, I can still have incident to billing under my name because I'm in what's referred to as a physician directed clinic. If you actually want to take a look at that, it's section 60.3 of the Medicare benefit. This is not the Medicare program integrity manual. This is the Medicare benefit policy manual, and it's chapter 15, covered medical and other services, section 60.3. So let me pause there for a minute and let me kick it over to Scott or Paul, or to any of our panelists if you have some thoughts on this.
Can I just interrupt one quick thing? I just want to
Sure.
say one thing, and then obviously kick it over. And I promise I won't monopolize. One of the things that that was said as far as the administrative versus the clinical, understand why this is there. So your physician has to be there in a clinical capacity to qualify under the incident 2. First of all, because you have to prove that they're in clinic. And if, let's say, they're at a day off, that they're catching up their charts and they're not on the schedule, I'm an auditor. I would look first for that. Was the doctor even there who was on rotation? And I've had this happen in depositions where doctors are like, well, I was there. I was in my office, catching up my charts. I'm like, you're not there seeing patients. And specifically in the rules, it says you're in the capacity where you're seeing patients. Secondly, try not to just use extra space you have if you don't have a supervising physician. One of my specialties is cardiology. And I see a lot of practices saying, well, the billing office has an extra room, so we're going to do all of our pro times, Coumadin checks for patients in an extra room in our billing office, and they could call our doctor if they need to, and we're going to bill it out into the doctor. And with that, Paul, take it away.
Well, I'd like to throw a little bit of a curveball with regard to the definitions of qualified healthcare provider. One thing that confused this, and something that we were not used to in the coding arena, was the addition of chronic care management and understanding that, yes, this is billed under the physician, but all of the work that's done, or quite a bit of work that's done behind that code, is done by what they call clinical staff. And that could be anyone really under the aegis of the physician's practice, putting that stuff together. And there are documentation standards for that we could do a whole another episode on. But it's important to make that determination. I'm glad that we kicked it off by making a differentiation between clinical staff and qualified healthcare professionals. And getting back to your infusion center point, understand that, yes, that does need to be staffed by qualified healthcare professionals, whether that be a physician or a non-physician practitioner. But one other thing that we need to remember, and something that keeps coming up, is that I get a lot of questions on supervision and what the supervision requirements are. And understand that infusion services, every time I look into this between Medicare regulations and the Medicare physician fee schedule, there are no direct supervision requirements for that service. It just requires that a qualified healthcare professional be there to perform those services.
And Sean,
Yeah, go ahead, Christine, please.
Drew, just to remind everybody, this is a Medicare benefit. We're about other payers. We're not talking about Medicaid. We're simply talking about, it's not that any of the other payers align with this methodology. So you'll have to check with it. Some payers, the Uniteds at one point wanted the SA modifier to do this. So make sure that they're checking with their specific payers and that we're Medicare. Yeah.
I mean, and we have several topics that we want to make sure that we get through tonight, but I can't underscore the importance of getting incident to billing correct. folks, I'm not even talking about split shared services. We'll talk about that down the road. This has nothing to do with split shared services. This has everything to do with incident to billing provisions in the office setting, or in what they refer to as a physician directed clinic.
There's
right.
there's an
Go
interesting
ahead.
thing I do want to add to that. I know we want to move on, but I'm asked this question all the time, and one of the changes that was made to the Medicare rules this year was essentially not allowing, we'll call them split shared services in the office setting. So there was always this sort of hybrid where, and I'm asked this question all the time. Well, it's like, why don't I have the nurse practitioner document the history and the exam and all these other pertinent components, and I'll come in and I'll do the plan of care, which is really more of a split shared visit. And that I don't know what you want to call it, but that was pretty firmly closed, I think, with respect to these documentation guidelines, where you can't do that and then say, well, the physician created the plan of care. A second thing I just wanted to say about stressing the importance of the administrative factors enough. As I often say about incident to services, right after I say maybe you shouldn't do them, the burden of proof always sits with you to prove certain things, right? And so when you talk about the administrative things, I think that's important to not, it's important to focus on. Like, you have to be able to prove, to take in things that Terry and Sean both said, that you had a physician that met the requirements of incident two who was in that clinical setting doing clinical work. And so if you don't have some mechanism to prove that, whether it's, log in and log outs, or some way to show that you're logged in and engaged, then you're taking on that risk, right? And I think those are important things to think about.
I think that's an excellent point, Scott. Absolutely. And one of the things, Terry, I'm never going to take credit for the stuff that you share with me. I'm just not going to do that. I'm not that kind of guy. But one of the things that Terry brought up, and I agree with her 100%, is the most recent MedPAC study showed that about $94 million a year in losses were tied directly to indirect billing. So keep in mind when, indirect billing when incident two was allowed. So Medicare, there's no doubt, CMS, HHS, OIG, they are all focusing on incident to services. Scott, I go back to an interview that I did with Seema Verma that you were an integral part of, right? And the fact that Seema, when we talked to her, we had heard some rumblings that incident two was going to go away. And the very first thing that she said was, not under our administration, but we are planning to clarify more guidelines. We are planning to push out more information and clarifications on this. And I think one of the last things, I mean, we could talk about this all day long, but I think one of the other last things that I want to talk about with incident two, because I get this all the time. Can you bill incident to a physician for another physician? Well, be careful. Be careful.
I'm staying
before you
face.
say no.
I'm staying face neutral, because I know I was in a conversation with a fairly high-ranking CMS person many years ago, who explained that it was in fact possible, but like frowned upon. But there was no specific reg to point to that did not allow it, much in the same mechanism that a nurse practitioner would be in that function. But it typically had to do with, at least as I remember that aged conversation, it had to do with enrollment pending stuff, and just situations where there were credentialing issues. And I would not, I don't think I would endorse it, but we
Yes.
had heard of that, and it was just it was one of those things that frustrates the bejesus out of you about CMS, where, nothing says you can't do something, and then you ask and you get kind of, like Fred Astaire ballroom dancing level of answers, where all you really want is yes or no, and you're getting like the 500 word version of whatever you're asking.
Well,
So go ahead. Hold that thought for one second, Paul. Just 1 second. Christine Massey and Lady Martinez, we'll get to your questions here in just 1 second. I know people don't like the concept, but CMS has literally put it into writing on their letterhead that they will allow physician to physician incident to billing. I know it drives people nuts, but just listen to this one piece. The Centers for Medicare and Medicaid Services is verifying that a physician can bill for incident to services rendered by another physician as long as all incident to criteria is met. Medicare's incident to requirements are primarily contained in the Code of Federal Regulations. So this has been codified under CFR 410.26, and it is in the Medicare Benefit Policy Manual, Chapter 15, Section 60. So it is codified in federal law, again under 410.26, and it is in the CMS Medicare Benefit Policy Manual. Please don't go to Chapter 15 of the Medicare Program Integrity Manual because you won't find it there. It is in the Benefit Program Manual. Okay,
You'll find
Paul,
a bunch of other things you can't do in that other section.
Yeah. So I was so
Can't do
rude,
it in
Paul. I
California.
apologize.
No,
Yeah. Go ahead,
that's
please.
quite all right. That's quite all right. The one thing that I wanted to point out is that even though physicians are scientifically trained, let's not think that for a moment that they're not incredibly creative when it comes to issues like this. And I think that Scott touched on it a little bit with regard to credentialing. Well, where he or she is going to join my practice, but they're not here yet. So all of a sudden, I begin to get a lot of questions about not only incident to, but let's try to do some locum tenens here and try to pull them into that. And, locum tenens is substitution. It's not meant as a placeholder for, well, their insurance contracts haven't come back yet. That's not what it's used for. Just a quick reminder.
That's right. And Paul, is that in reference to the question that Christine Massey is asking? Because I could see that tying into it. So keep in mind,
Yeah.
The question is, and Terry, since this was actually addressed to you, and I know you can't respond for some reason to the questions, but Terry, if there is a clinician covering and checking or supervising, do they have to have patients scheduled?
There has to be a way to reflect that they're there in a clinical capacity, not in an administrative capacity. So that, yes, that's the only way to really do that, to prove that they're not just working from an administrative perspective. And then also something that you were saying as far as the incident to for physician to physician, know your state. Whatever you found in the specific rules of Medicare, California, for example, I just pulled it up, they said no. And Noridian says no. So it has to be specific to also your state. They don't want anyone kind of getting around the rules, if you will. So they said you cannot do physician to physician because it doesn't meet the criteria, in their opinion, of incident to. Incident to is for mid-levels under. And remember, the doctors are trying to do it to get 100%. And it's if they're not credentialed yet and don't have privileges and things like that, you're barking up a tough tree. I kind of agree with Paul and Scott on this. It's not best practices. Let's put it that way. If we're going to defer to anything.
Go ahead,
Well,
Christine. Go ahead.
About credentialing part of it, that credentialing piece once a long time ago, Terry, because when I was one of the first things I always say is both providers need to be enrolled in the Medicare program, exact words, but I think that the wording says that in the event that doesn't meet the requirements, oh, by the way, I've got a new problem, or this is not working. You don't want to stop midway and say, oh, wait a minute, sorry, I can't finish this visit because I'm not credentialed with Graham. I'm gonna have to go get somebody else from the office to do this. So, I mean, the way that I always kind of both have to be enrolled in the program in order to be able to provide this service. So it's not
Go ahead,
waiting
Scott.
for.
Yeah, no, you're spot on, Christine. You're spot on.
I was just going to say, we've talked about multiple derivatives of incident to, right? And the different types of it. And I've heard state scope of practice questions about a nurse practitioner supervising the technical component work of like radiology and things of this nature. And so, I think sometimes my concern when I talk to practices about any of these multiple incident to things is they just see the dollar sign, right? They just see the 15%. They see, they don't get that. They're not as thoughtful about the fact that there are very technical component pieces to each different derivative form of incident to. Like even when you say incident to in our world, from a Medicare perspective, that's like a couple of very different ways to do that, very different service types, each with their own set of rules and regulations. Like I always talk about incident 2 in the perspective of a nurse practitioner and a supervising physician, because it's impossible to predict what a patient's going to say in an exam room until you're in there and the patient blurts out, well, here's this other thing that's going on, right? And so I think you just have to be incredibly thoughtful about what your workflow is, and that all of the people who have their hands in this process understand when to sort of withdraw, right? So if you're thinking about incident 2, you have to understand that regardless of your best intentions, it's probably not going to be a situation where you say, this is always incident 2 in this model. There has to be a time when you pull back and say, well, these X claims go out under the nurse practitioner because they clearly don't meet those guidelines. And you have to have the sense to, rather than try to steer the boat around that, to just say, this is where we're at.
I'll also
ahead,
add
Paul.
one last very quick point, because I know we have some other subjects to cover.
Yep.
You mentioned very briefly, Scott, state scope of practice. This is where collaborative agreements come into place. We haven't even mentioned that. Be very careful about the wording of your collaborative agreements and who is covered under that collaborative agreement. Just because you have a non-physician practitioner who's employed by the practice doesn't necessarily mean that every single physician under that practice is allowed to supervise that specific provider.
That's right. That's a great point. And I do, because we did call it out, and this will be the last one on incident 2, and then I want to move on to the next incredible topic. Lady Martinez, I want to be very clear. On incident 2, you can never bill a new patient. There is absolutely zero new patients. So irrespective of whether the patient or the physician is on the premises at the time the services are being rendered by a non-physician practitioner, or if they are at another location across town, it doesn't matter. It's irrelevant. You can never bill incident 2 as a new patient. Why? Because the whole premise behind incident 2 is that the non-physician practitioner is carrying out an established plan of care that was put into place by the treating physician, MD or DO. So great questions. Lots of great comments that I'm seeing, but I want to move on to our next
Don?
Yeah.
Oh, sorry. I have to run. I'm so sorry. Of course, this is just a premonition, right? But we're going to see CMS jump in and make a change to here in the near future. I think it was more important that they clarify split and share, go any further with their E&M changes. But if my ball's correct in the future, I hope.
Take care. Be safe, Christine. Thanks for joining us for this first half hour. We'll see you in a couple weeks. All right. Scott and Paul and Terry. So we and it's my pleasure, lady. I'm glad that we're able to clarify that. All right. So I want to talk about, if we can, is anybody up for talking about modifier 59 in the X modifiers for just a couple of minutes?
Sure.
Stop laughing.
We're all
Paul.
laughing. Yeah, we're all laughing.
Yeah, it's only been.
First of all,
yeah,
I want
it's
to
only
know where
been.
Paul moonlights. I think you're a disc jockey in the evening, and you have the voice that reminds me of, Good Morning Vietnam, the guy that came on at midnight and was all smooth talker.
The jazz
So.
guy.
Yeah.
We like
Okay,
to say
sorry.
Paul. We say Paul has a voice for radio, and I have a face for radio. That's how we've
geez.
always. Sorry.
All
Well,
right.
coming up after this topic is a smooth block of buzz.
There you go.
There we
Perfect.
go. Outstanding. All right. So here we go. So the modifier 59. I'm going to give it from a very, very high level, and then I need the experts to really jump in on this. Okay. So the modifier 59 is a distinct procedure or service. Okay. It can be done at a separate session on the same date at separate anatomical areas on the patient. But it is a red flag modifier. It is a modifier of high interest because it is one that is used to circumvent if you will, the National Correct Coding Initiative edits. Now, as part, and I'm staying very high level, as part of that, the Centers for Medicare and Medicaid Services rolled out 4, if I'm not mistaken, 4 X modifiers. And those modifiers are used at different points to provide greater specificity for why we are asking for separate payment on separate services or separate procedures. So I'm going to stop there because I sounded actually pretty intelligent on that one. And if I go any further, it's just going to turn into a debacle. So let me stop there and let me turn it over to the first of the brave panel who wants to take on the modifier 59 and some of the X modifiers, because I know the XU and SXS are 2 that create a lot of confusion. So
Okay.
take it away.
I'll jump in first. Well, as you can tell by the color of my vacation beard, I've been doing this way too long. And when I first became a certified coder back in 1998, I was told the 25 and 59 modifiers are going to be the biggest problem. Well, here we are, just 1 year short of a quarter century later, and guess which modifiers are still the biggest problem as a coder? So 59 has always been a problem because, you know, the NCCI edits basically say you have an edit. And unless it is identified as what I call a fatal bundling edit, in other words, the 0, then, you know, you can add that, you can theoretically add that 59 modifier. Well, here's, you know, and the reason why the X modifiers were brought out was that the 59 just says distinct procedural service. The X modifiers went into a little bit of detail as to why that is a distinct procedural service. And separate structure or separate encounter or separate provider are the 3 that are used most often. But there better be, in your operative report, very specific instances as to why that is split off, whether it is a completely different structure. I've seen this, you know, being the spine guy here, I've seen this a number of times where, let's say, the patient has had instrumentation removed during the procedure, okay, and it is at a different level than where they are performing a new fusion, but let's say that instrumentation, the new instrumentation that's put in, is overlapping with a spinal level where the old instrumentation was. You know, here we have a bundling issue, and I would highly recommend that you think twice about using any 59 or X modifier in that case, because yes, there is an overlap. So that's kind of how I look at it from the 59 modifier perspective. And just because it says a modifier can be added to bypass the edit doesn't necessarily mean it should. Every single case is going to have very specific instances, and those instances better be documented, because at the end of the day, that's where the rubber meets the road.
And to Paul's point, when he talks about a fatal edit, he's talking about the status indicator of 0. There are 3 status indicators. The 0, which means under no circumstances can you ever unbundle these 2 services. The status indicator of 1, where you, under certain circumstances, with the use of an appropriate modifier, can unbundle them. And then a status indicator of 9 means that it is the bundling edit is not applicable. I've always struggled with that one as to what does that really even mean? But Terry, let me kick it over to you, and then Scott, I want to come to you last to wrap up the modifier 59 and the X modifiers.
So what I try to do is I try to bring it back to basics, because I think sometimes people kind of default to, well, this is what we've always done, instead of actually read the directions. And so when we are in the CPT book, you have to actually read through it. And I notice when I do any kind of modifier presentations, and I do a lot of them, this modifier comes up and we spend some time on it, because what the CPT book says is it says under certain circumstances. Okay, so that's not always. And how many practices do we have that want to bill it all the time? Yep. So it says it may be necessary, again, not all the time, to indicate that a procedure or service was distinct or independent from another non-E&M service performed on the same date. And it talks about what it identifies that are not normally reported together. Well, if you're already always reporting it together, again, you're not meeting the definition. it talks about different session, different procedure, surgery, different site organ, keep going. Now, again, it says not ordinarily encountered or performed on the same date by the same individual. And then it says, however, when another already established modifier is appropriate, it should be used other than the 59 or rather than the 59. So not only does it say certain circumstances, maybe you'll use it, it may be necessary, not all the time, but it says this is your last resort. Please do not default to the 59 modifier. Then what happened is, because everybody was doing that, I think back in my days when we had the, for orthopedic, so the medial meniscectomy and chondroplasty. Oh my gosh, what was in a separate compartment? Stop. So what did they do? They combined the service. They basically said, you know what, this is not something you can bill for. So what happened is that they said, well, we're going to give you some, I call them the stepbrothers of the 59 modifier. So these modifiers was interesting when they came out in 2014, I think, maybe earlier. But basically, when this came out, CMS only issued one directive. They never followed up on anything. They just said, here it is, figure it out. And we kept trying to get more clarification. So the XE modifier, separate encounter, a service that is distinct because it occurred during a separate encounter. I love this modifier. For example, in, let's say, gastro, got a patient that went in and had a colonoscopy. They are put in holding, getting ready to go home on observation. And all of a sudden they have a spontaneous bleed and they got to take them back in and do a control of bleeding procedure. Well, if they just use 59, it's going to look like you're trying to bill for two of the same procedures during the same session. That's not appropriate. But the XE further describes that. The XS, separate structure, they don't even know how to use this, because when I talked to Medicare, I think there was one that was a liver biopsy with a kidney procedure. And they said, well, here's an example. I'm like, they're not bundled. That's not an example. So I'm like, okay, thanks for your help, though. We use it sometimes if we do a heart cath with an abdominiotogram, because that does have a one indicator, but, sometimes they don't know what they're doing either. Separate practitioner. So this is something that came out in a transmittal later on. The XP modifier, a service that is distinct because it was performed by a different practitioner in the same group practice. They didn't say that to start. So this is helpful because sometimes and I'll just bring it back to cardiology, your physician sometimes can get discounted when it's not their fault. You've got a cath physician that isn't an interventionalist, and now a separate practitioner may be taking over for another procedure. Or the doctor, let's go back to GI, that one where the patient had a bleed and they had to go back into the endoscopy lab, that doctor went home. And so now another doctor from the same group practice comes in to complete it. So now your modifier isn't XE, it's XP. And then the last one, which is the XU, that's the non-overlapping service. So these are things that tend to get kicked out routinely. They may or may not have an edit, and it's just because it's a payer decision. We see them every once in a while, but I don't think they really know how to use it. And the last thing I'll say, and then I'll send it over to Scott, is that remember, these are instead of the 59. Don't use them in addition to. Okay, so if you're thinking of a 59, go to these X modifiers first and say, wait, is this a better situation? And if you don't have any of those situations, but you're trying to bypass an edit for a valid claim that isn't ordinarily encountered, then the 59 would be more appropriate. But just make sure that if you're using it, you can support it. If you can't support it, then you're going to have a problem.
That's a great breakdown. Scott, why don't you wind us up with the modifier 59, because I want to come to you on some other modifiers.
So I've been thinking about this while everybody was talking, and unfortunately, Paul and I are like the only big like pop culture people. And I was trying to think of what the X modifiers are like to me, and I'm struggling maybe like New Coke, right, where there's a much time and energy put into these, and like nobody uses them, and so I rarely see them in my work. But the things I'll say about modifier 59 is I think it's important that the provider's mindset sometimes in my conversations with providers are they're just using modifier 59. They're just putting it on things. People are just slapping it on things. And it's like, I want you to explain to me why this is different and distinct, rather than me as the anti-modifier 59 person having to explain to you why it should be bundled. Like, it's bundled as a default setting, right? And so when I think about modifier 59, I find that the NCCI manual is sometimes a very valuable place to find little nuggets about their thought process. But I'm asking myself, when I'm looking at a claim, what about this particular claim qualifies these two services as different from an assumed thing where they're together? Like Paul and I recently looked at an encounter where there was a bundling edit where one entry point was interior and one entry point was posterior, but they were bundled. And, you know, the client that we're working with is coming back and saying, well, it's two different incisions. And I'm going through my head and I'm saying, well, then why did they create the edit? You know, like, and I think sometimes those are things that we have to think about. And I think it's always about that person being able to answer that question. Now, where I think the X modifiers have value, even as they're not used as much as we would like, is they do start to dive into that. It does start to tell you, does it fall into one of these buckets in a way that leads me to believe that modifier 59, which is really just the master of these X's, would be more appropriate to use in this specific situation. So, you know, to me, it's like a mindset with modifiers, and it's a mindset where I find them on things where I know they don't belong, like modifier 25 in a lab service. I think we talked about that last week. And at some point, it's really about honing in on, when is it appropriate to use this modifier? And can you explain to me as the user of it, why you feel this deviates from the fact that these two services were put together for a reason? And that's, to me, it's as simple as that. And if you can't do that as the user, you know, as I say all the time, the burden of proof, the onus is on you to use this thing the right way. It's not on me to disprove it.
That's right.
I want to bring up something that I thought was funny that Scott said too, and I'm sure you guys all see this. How many times? Okay, so for the audience that's listening in, watching in, however you're accessing us, one of the things that we can usually do, and I say we collectively, the panel that's here, we can look at a claim form, we can look at it, how something was coded, and almost, especially if it's our subject matter expertise, and we can go, oh, okay, we already know what's wrong with it. And then we go through and say, let's just verify we're, you know, on the right path. And I can't tell you how many times I see claims that somebody will say, we're getting denials, and the 59 is on every single line item. It's starting at the top. And I'm like, wait, you have to have a base code. And then you say, well, this one is the one that's, you know, got to want that one indicator edit going to that one. So you have to know also the rules of coding. Stop laughing.
Well, and I think,
you know,
so what,
I know.
Well, and
I know.
one thing I did want to add, one thing I did want to emphasize that you had said is that modifier of last resort is very important to consider too, because I see it used for like laterality when it should be like RTLT.
That's right.
You know, and so I think it's important to understand that, you know, in addition to having to justify its usage, you also have to walk through other modifiers and they're perhaps being more appropriate for the specifics of that service.
Right. You also have to deal with the conflicts of CPT. If you're doing lower extremity, let's say stenting, CPT actually, they said if you do right and left leg, you're supposed to use a 59 to denote a separate extremity. But if you do the exact same service, you would think, just from a coding perspective, it would be 50 or RTLT. Because it's bilateral. No, not according to CPT. So it's like, okay, well, so now it says it in Appendix A, and then we have to go back to the section and say, well, what are you telling us?
Yep.
So
go ahead, Paul.
Just very quickly to put an exclamation point on this topic, because I know we're running short on time. Terry mentioned doing things as a matter of course. I mean, this is a compliance podcast, and you know, I don't know how many of you have mastered Philadelphia French the way I have, but we all know the 7 dirty words that George Carlin brought to America in the early 70s. The 7 dirty words of the compliance professional are, but we've always done it this way. As soon as you hear something like that, bells and whistles should be going off. A big red stop sign should be popping up in neon all around the practice to denote that something is wrong and something needs to be corrected.
Yes.
Something wrong. Okay. Yeah. I agree 100%. We've always done it that way are the words that if I show up at your practice, you should never say to me.
No,
ever.
But we've always done it that way. We put 59 in all the drug codes. Oh my gosh.
All right. Scott, I want to stick with you. I want to stick with you on this one because there's 3 more modifiers that are a complete pain in the butt. A bunch of modifiers are, but for some reason today we're talking about, I don't know.
Hemorrhoids and pains in the butt. Yeah.
Yeah. Before we go down that road,
Yeah,
which is
Sean.
a gravel road, I'm going to pull us back onto the pavement. I want to talk about Modifier 91 first, okay? So Modifier 91, repeat laboratory services. This is a modifier, again, that is being used incorrectly. You're doing an audit. You just ran into it. What's going on?
So I think, and of course, we're going to have to talk about Modifier 59 here a little bit, but Modifier 91 is a repeat of the exact same thing that you did for some reason medically necessary at a different time during the same date of service. It is not doing some other service that happens to be represented by the same code. So the most common thing I could think of for lab services that we see all the time, and people on this group probably know about, is like flu A and B, 87804. If you do that test on flu A and flu B, it is not a repeat service. It's a different service that so happens to be represented by the same code. Whereas Modifier 91 might be that you're measuring a patient's like potassium level, exact same test, because you measured it, it was out of whack, you did some type of intervention, now you want to come back later on and see if that intervention was successful. So you're going to test the same thing in the same way. But if you're taking a sample from a different part of the body, that usually means Modifier 91 may not be appropriate. Or if you're doing a different test that just so happens to be represented by the same code. So in some respects, what makes it interesting when you think about Modifier 59 as the modifier of last resort, when you're talking about lab services, you should be steering through Modifier 91 before Modifier 59. You shouldn't be doing it in the reverse. And if you do it that way, you'll end up with the right modifier, because you'll steer through to Modifier 91 and you'll say, is this the exact same service done in the exact same way for the exact same reason? Yes, Modifier 91. If you say no, you're going to move on.
Absolutely. Well said. And, before I get to the other two modifiers that I wanted you to talk about, I agree with Samantha Patterson 100%. Modifier 24. Seriously, I don't understand why so many people mess this one up. It is an unrelated evaluation and management service during the postoperative period. I mean, listen, I'm not the brightest bulb of the bunch, but even I can read where it says unrelated evaluation and management service during the postoperative period. But yet it's a modifier creating all kinds of problems.
You know what when I see it most commonly incorrectly used, it's complications. It's something that the provider mentally feels like takes more work and therefore warrants separate payment.
Right. And I also see it, especially in orthopedic, where a patient comes in with an infected site, or they have, maybe some fluid at a knee after a knee procedure in the global period. And here's the kicker. They'll say, and actually this came up this morning in a meeting I had, they'll say, well, how can I use a 24 for an infection if they're taking them back to the OR for a related procedure and I'm using a 78? So doesn't that make a difference? And so then I had to say, okay, so let's look at the clinical makeup of the patient and the profile. One thing that we do is when we submit claims, we're trying to explain based on codes and the total health picture on the patient, what's going on. So when the patient comes in for an infection, we don't know that infection is actually related at that moment to the knee. Remember, there is a global period for that normal recovery, standard of care recovery for that patient. As soon as there is, like Scott said, a complication, infection, something that the doctor now has to work the patient up to figure out what's going on. That's not just the patient coming back in, within the 90-day global and saying, I still have pain. Well, of course you do. You just had surgery. But this is not trying to be flip or anything. Sorry. But I see patients with total joints saying, I'm still hurting after 6 weeks. I know you will.
And we will be talking about the Ruan case coming up, which has to do with the Substance Control Act. So we will be talking about that one. But no, you're right. Go ahead, Terry. I'm sorry. I didn't mean to interrupt.
No, that's okay. But with the 24 modifier, it's really your physician call, as long as, again, it's not related to the diagnosis for the procedure that makes that a 24. Now, if you have to take them back in for surgery for either anticipated, non-anticipated, or greater, depending on 78, 58, whatever, it's something that you can definitely support. Now, here's the kicker, and actually I'm going to either ask Scott or Paul to comment on this one. Let's say you have the patient come in for their new patient visit and they have bilateral knee problems. And I don't know why we're talking just about ortho. That could be anything. But ortho is a good example here. So let's say they come in and then in their global period, now the doctor wants to talk to them about the knee that they didn't take care of. Well, now, is that really unrelated? Because it was related to the initial visit. So where's the relationship there in context of that modifier? And I'll let you guys chime in on that one.
Okay. Well, I'm going to rewind the conversation, and I got a visual aid just to show it. Anybody ever read the surgical guidelines page of CPT before the surgical CPT section? Because
I did that right when I came out of anesthesia for my last surgery.
Yeah,
I couldn't wait to read it.
2 sections you need to focus on: CPT surgical package definition, the last bullet point, typical postoperative care. And then 2 paragraphs later, follow-up care for therapeutic surgical procedures. Complications, exacerbations, recurrence, or the presence of other diseases or injuries requiring additional services should be separately reported. Well, Sean, what do we always talk about when we talk about medical necessity? Generally accepted standards of medical practice as defined by the physician. And again, it's all going to come down to documentation. How is this 24 modifier E&M that you're attempting to bill distinct and separate and unrelated from the surgical procedure that you've just performed? I mean, this is the starting point, is the surgery guidelines, and it's been there and it hasn't been modified in years. I know, because I've been around for years. Keep looking at it, but use that as a starting point when you're talking about the modifier 24.
Well, and Paul, you just gave them their authoritative reference of published guidance if they have to appeal a modifier 24. So now you have a chapter, verse, page number, everything.
Mm-hmm.
Yeah, there's 2 things that have happened one time in my life. Haley's Comet came one time, and I audited a claim once where I actually added modifier 24 and changed it to a billable code. And because going back to those guidelines, right? Like, this provider was so used to just, I do everything in the 90-day period. And this provider's note was just basically like, this surgery did not work, and I'm addressing the underlying condition, and I'm doing like these different things. And I'm like, okay, now you're not treating, this is not a surgical post-op, at least as you're documenting it. And that was the conversation, right? Now, whether he was documenting as well as he could have, I'm not sure, but it was really more about recurrence rather than global.
Great points. Yes, I saw Haley's comment once too. Doubt I'll see it again, but saw it once.
Yeah.
Okay, so let's go.
I saw the bicentennial, so there we go.
Yeah, we'll come back to that in a minute, Paul. So, Scott, I want to go back to two last modifiers, and then Paul, I'm going to have you round out for us in the last 7 minutes that we have here of our program tonight. Scott, 2 modifiers. They're cousins, distant cousins, first cousins, second cousins, however you want to say it. The modifier 76 and 77. These tend to be problematic modifiers as well. Let's quickly talk about
it. And frankly, again, not a lot different from 91. Like, you're traversing these modifiers on your way to modifier 59. The most common service I see modifier 76 on in my universe is the interpretation of an EKG. When the patient has received multiple EKGs during the same session. Modifier 77 is somewhat similar to 76, except it's a repeat procedure by another physician. And it indicates that obviously there's medical necessity involved. So again, when we say repeat, like, we mean like repeat, right? So repeat is the same thing. So I recently had modifier 76 done for a procedure done at different levels of the spine. And I'm like, well, this is not a repeat. This is a distinct, and in some cases this is done by units, right? But this is not, you're not repeating something because you're doing it in a different place. And so I think those are important things to think about when we think about, okay, we've just spent a half an hour talking about how modifier 59 is misused, but there are times when you are going to end up with modifier 59, but you may get led astray by these other modifiers that seem like they describe what's happening, but in reality, they don't.
Great explanation of those two modifiers. All right. So I think we've beat up several modifiers, even one that I don't think we were planning to 24, but thanks to all of you, for chiming in. The last thing that we want to talk about tonight, again, this is extremely important. This has to do with physicians who are in a foreign country taking care of US based patients and wanting to submit claims for these services and be remunerated for it. So, Paul, I'm going to turn it over to you. But Terry, you and I have talked about this before. I seem to remember, and I think you had some pretty good insights on it. So, Paul, kick us off, and then we're going to kick it over to Terry from there.
Well, because we're running so short of time, and this was a fairly big topic, one thing that I'll say is that at the end of the day, when you have a doctor who's overseas, it's very important to understand what their primary clinical focus is while they're overseas, attempting to care for domestic patients. And the biggest question that you have to ask before you ever get down that rabbit hole is, does it count, and where's the money going? So I'll start that off as a very quick exclamation point to the topic based on how much time we have, and I'll turn it over to Terry from there.
Well, and we had talked about it from a telehealth perspective, I know, a little while ago, and they've actually added some rules to the Social Security Act on this. But bottom line, Paul is correct. And it's also about being licensed out of state and the regulatory provisions from or out of country, I should say. So what the Medicare rule is in a nutshell is they do not pay for out of country services. They don't send checks out of country. They don't send transmittal of money out of country. So, but what they do, and this was just a little note. So let's say a patient the Medicare patient needs to have an ambulance to go to a facility, let's say in France, okay, and they're out of country. They'll pay for the ambulance. They won't pay for the treatment.
Yeah,
okay.
Makes perfect sense.
Makes perfect sense to me. So at that point, I'm going to say, you know what, Sean, that's another day for that conversation.
Yeah.
Yes,
and I'll just leave this one point to linger on in the ether. Do not get sick on a boat.
No, do not get sick on a boat. Yeah, cruise.
Well,
no, you're in trouble.
Stopping right there.
Well, hold on. I am going to defend the cruise lines for just a minute. I will say this, okay? For years, I used to fly around the world for celebrity cruise lines, for celebrity. There were like three. This is how old I am.
Celebrity Carnival.
No, I didn't. No. I never did Carnival.
Not the White Star Line, I hope.
Yeah.
No. But it's the one that starts with the N.
Norwegian.
Thank you.
Yeah.
So I did Celebrity, Norwegian, and I used to fly to a port. I'd get onto the ship, and then I'd fly from wherever the next port was to the next port and get onto another ship. So it would be nothing for me to work on 2 or 3 ships a week. And I will tell you, Celebrity and Norwegian, they subscribe to the United States standards of healthcare. Their surgical theaters that they have on these ships, the medications, the quality of healthcare providers that they have. And we see a lot of bad publicity from mainstream media, and we read some things that aren't so great about them. I will tell you, as somebody who was certified to go and work on these ships and to make sure that they were up to a certain level, Celebrity back in the 2000s when I was doing this had relationships with the University of Miami. So anything that would happen, if they had a cardiac issue, if they had something that was going on, it would go straight to the University of Miami. If they had peds, it would go to Children's Hospital. So, yeah, I mean, obviously, I'm not going to mention any cruise lines by name, but there are some that I will never go on. But
so what you're trying to say is that it's not just Bernie Capel giving out aspirin?
Yes.
Okay.
And with that, we're going to stop. So, folks, this was an absolutely brilliant conversation right up until the point where I almost ran it off the rails, as I tend to do. But I cannot tell y'all how much it means that you're willing to take time out of your day at the very end of what I know has been a busy and productive day to hang out with myself, our panel of unbelievable subject matter experts, Terry Fletcher, Paul Spencer, Scott Kraft, Christine Hall. Y'all have been fantastic. To each and every single one of you that's been engaging with us throughout this entire hour, can't tell you how much that means to all of us. You're the reason why we do this. Coming up on the Compliance Guy podcast tomorrow is our hashtag Terry Tuesday. Great segment. I'm so excited to do it. And we have so much to talk about on telehealth. I think some folks are going to be like, oh my God, how did I miss that? Wednesday, we got the Daily Dose. Thursday, we have the main episode coming up. I had Maggie Parrott, who is the corporate compliance officer of a Medicare Advantage plan, who actually was brave enough to come on to the podcast and sit down and do an interview with me. It's going to be airing. It's going to be streaming on Thursday. And then Friday, of course, we'll finish out the week with our Daily Dose. So until tomorrow, y'all be good to yourself, but more importantly, be good to each other. We'll see you tomorrow.